And we are live.
Good evening, everyone. I hope all of you are well and connected to us. Thank you for connecting to us. We welcome you to the new episode of Covaxin Chronicles. Today, we have with us Dr. Amitav Banerjee, who is the professor and head department of community medicine in DY Patil Medical College and Hospital, Pune. Dr. Amitav has served in the Indian Armed Forces from 1978 to 2005. He has done very extensive work in field of community medicine. And today's topic is about how COVID has impacted our Indian healthcare policies and what is the level of what is the health status, what are the statistics, and what is the health literacy that is there in our country right now. So I would request sir to please start the presentation without any further ado. Welcome on board, Dr. Amitav. I please request you to start your presentation.
Thank you, Dr. Unnati, and I am very grateful to Dr. Precious to opportunity to interact. So today I'll be discussing about the impact of the response policies on the public health, and of course on the something I'll be touching of the health literacy which is required. So I will just first give us a small presentation, and then we can have any discussion. So I'll just share the screen. So this is the topic today, the impact of COVID-19 response policies on public health and health literacy. And this is important because we have been focusing on COVID-19, and in the meanwhile, we have got a number of other health problems. We have got other non-COVID conditions. We have got economy. We have got poverty. We have got unemployment. So how do we go from here? I mean, COVID is a lot of measures were taken. So this would be the scope of our discussion. What was the global response, India and the world? What were the basis of these responses? What impact these responses had on COVID-19 firstly? That was the purpose. Then on known COVID diseases and on health literacy. What are the health literacy or the awareness, health awareness, or the uh, fault lines which were unearthed because of this COVID? What are the learning points? So what was the global response to the pandemic? You see, China set the pace, and initially the world thought that it would be a whatever measures like lockdown and restrictive measures would be for a short time, but it has turned out to be a marathon. It's more than a year and a half, and we are still struggling with it. Repeated lockdowns, episodic interruption in businesses, or schools and colleges are still closed. So anyway, China put only one district under lockdown, and in spite of that, the novel virus hop stepped and jumped from Thailand via Thailand to Italy. Italy was the first country after Thailand which was heavily affected. Italy, there was a very heavy casualties, and it clamped a nationwide lockdown. So and other countries followed in a panic, and except for a few countries like Sweden, most of the countries went for lockdowns and restrictive measures. Indian response, India, we all know, went for the world's largest and the most stringent lockdown in March 2020. And we know the thousands of migrant workers were left stranded and walked miles on foot to reach home. And these are some of the collateral damages which we may have to cope in times to come, would be the poverty, unemployment, and destitutions. And this would be a global problem, and the developing countries would be facing this more than the developed countries. And this would be the global impact on public health of the response policies: devastating social and economic disruption, extreme poverty, increase in malnourishment is projected to be 130 million. Presently, it is 690 million. This is the global increase in malnourishment, particularly child malnourishment. And the marginalized workers are most badly hit, particularly countries like India, where the most of the workforce are in the unorganized sector, where don't have any network, social net safety network. Social distancing in letter and spirit, rich poor gap increase. So we say social distancing is not a good word. We should do physical distancing, but actually in letter and spirit, The gap between the rich and poor have increased after this pandemic because the rich have become richer. Their businesses have not suffered. They have been able to work from home, and some of the businesses has thrived, particularly which depends on digital platforms. And the poor people have become poorer. So there has been really social distancing during this pandemic. Impact in India during first lockdown, 10 million people returned to their villages, many on foot, some on bicycles, we know. And there are estimated 400 million people will fall into poverty. So these are the future public health challenges which we will be facing. Impact in India. Health services, this was the COVID exposed the deficiencies in our public health infrastructure. Particularly, people in the second wave was quite devastating, and it affected the rural areas. Unlike the first wave, which were confined to the metropolises of big towns and cities, this time the rural areas, because of to and fro movement of the migrant laborers, so it overwhelmed. As we know, the health services in the rural areas, even at district levels, sometimes are not very good. So it overwhelmed the inadequate health services, and also it affected the non-COVID cases because all beds, most of the beds were reserved for COVID cases, and besides that, people were afraid to come to hospitals for fear of getting COVID, and medical staff were overstressed, and there was burnout among medical and paramedical staff. They had to take care. They were exposed to infection. Then they, after the work in COVID, with COVID patients, COVID ward, they were sent on quarantine for a few days, initially for weeks, for a week or so. So that also had a adverse effect on the health manpower or human resource, health human resource. Increase in anxiety and psychological disorders among the healthcare workers and the general population. Particularly now it has got prolonged. People are facing unemployment, people are facing educational setbacks. So there is an increase in suicides, anxiety, and psychological disorders. Routine childhood immunization has also suffered. So we have fear that the childhood diseases will increase in days to come because these services have got interrupted. Education, we all know, is the biggest setback is in the education sector. Many may have long-term social, psychological, educational setbacks in the next generation. School dropout have increased, and it will be very difficult to cope up, particularly for the people lower down the socioeconomic status who don't have access to distance learning, who don't have access to tele-learning. So the gap between the haves and have-nots have increased. What was the evidence base for such drastic responses? Because this is important to really take stock of, because with the globalization, such epidemics can occur again. So we have to learn some lessons, whether we have done well here, or we have failed, or we have caused more harm, public health harm. So many people may be surprised to know that these school closures, physical distancing, and all these lockdowns were based on computer simulation school project of a high school student. A high school student in the year 2015, daughter of an American scientist, carried out a school project for simulation for control of influenza. That if you close schools, if you do physical distancing, if you do restriction, the transmission it will break the chain of transmission. This school closures, physical distancing, and because computer models are inert models, so they took the humans as units. So they neglected the social aspect of human beings, that it is just computer models, you can make them inert, you can make them stay in place, but people interact, people are social, they have to survive, they come in contact. And therefore, these things, how well it has worked, because we see from experience of some countries which did not have lockdown, like Sweden in Europe and Japan in Asia, the rates of transmission are more or less same depending on the geographical area. Sweden rates of transmission are same as say UK, or perhaps less than UK or other European countries. Similarly, Japan is also like Asian countries. So And then there are some states in USA which had more restrictive measures, which did not, and compared with others, there is not much difference to show that these restrictive measures have a great impact. Then, of course, there were the evidence was also initial cases. There were false prediction models by Neil Ferguson that millions of deaths were predicted. Because what happened, initial inputs for the model were taken from Italy, where the median age of death was 80 years, elderly people, and that without taking factoring for demography. Say other Asian countries, we have got younger population. The same model was projected, and also the models took the inputs from the admitted cases, which are serious cases. So subsequently they did some community surveys, some sero surveys. They found the infection in the general population is much higher than those admitted cases. So if the infection fatality rate is taken, it comes down to much less. So these models were based on wrong inputs, and there was a panic initially. So evidence of then there was the evidence for outdoor transmission. Even now we hear the caller tunes that don't go outside if you don't have work. But actually, this again was based on a misinterpretation of a paper, which CDC misinterpreted a scientific paper to conclude that the risk of outdoor transmission is 10%. Actually, one of the authors tweeted that it is 0.1%, not 10%. And this was some misunderstanding between the CDC and the authors of the paper. And this advice to stay indoors, wearing of mask when stepping outdoors. So this went into policy. I mean, these are knee-jerk reaction. Of course, mask will help more indoors rather than outdoors. Subsequently, it is well established that outdoor transmission is much less. So these fundamental errors of misunderstanding between the science and practice led to restriction of outdoor activities worldwide. Outdoor businesses were closed, outdoor parks were closed, and particularly in countries like India or poor countries, developed Asian countries, there is a lot of population density indoors. People lived in congested slums, people live in tenements, even middle class homes are very congested. So this restriction or stay in home, how well it has checked transmission is debatable. So whereas outdoor transmission is much less, and the wearing of mask is more important indoor, particularly if you are going to shopping areas or congested malls or something like that, rather than outdoor. But people are more particular wearing masks outdoors because the police and other people catch without mask. So anyway, that is some of the misguided policies, perhaps, which was actually in theory and practice there was much gap. Theory says the transmission is indoor, whereas practice the masks are checked outdoors. So these are some of the measures. Then the question comes: did the measures work? Such much drastic measure, did they work? After the first wave, particularly we'll take the Indian example. After the first wave, the countrywide seropositivity as carried out by the ICMR was 21%. That translates to almost 30 crore Indians were already affected. The virus has run, most of the cases must have been subclinical or asymptomatic. And the infection fatality rate after the first wave, because the fatality rate that time and the total denominator is the people who are infected, was very low in India. It was less than 0.08%. The global infection fatality rate as per the CDC and WHO is 0.3% infection. That majority of people get subclinical infection or asymptomatic people, and only few get other cases. Case fatality is something which is hospital cases or who are diagnosed with RT-PCR positive, and the infection fatality are the undiagnosed cases. For every one diagnosed case, they estimate there may be 20 to 30 people who go undiagnosed. So the denominator increases, the infection fatality is very low. After the second wave, countrywide seropositivity in some pockets, in some surveys, that is recent surveys, say June or May or June, the countrywide seropositivity, like in Ahmedabad, in Pune also they carried out recently a survey. In Pune, they found 80%, Pimpri-Chinchwad area, 80% seropositivity. After the first wave, we had carried out in the same area, Pimpri-Chinchwad, Twin Township of Pune, the seroprevalence was 34%. So after the second wave, the same area was 80%. So now ICMR plans to do a fourth survey countrywide. So that will give an idea. And we expect after, because the second wave was 3 to 4 times more intense than the first wave. So the natural infection must have run through the population. So most of these measures had very little effect, because if you see the transmission cannot be checked, because most of the infections are asymptomatic, most have got mild symptoms, and people in our country live in congested conditions. So once you do lockdown and other things, they are again pushed indoors and the transmission increases. Then what about school closures? Most of the countries closed the school, so we have got only few countries like Sweden is the only country which kept schools open during the pandemic. And this is important for us because we are every time contemplating to open schools, and there is a serious debate whether to open schools or not. So Sweden kept the schools open and they collected the data, and there was no excess mortality or morbidity in children or teachers compared to previous figures. So no triggering of community outbreaks from schools reported. So there are three concerns. Whenever you are considering of opening schools, there are three concerns. That is the mortality in children or severity of disease in children. Secondly is whether children can transmit to the adults when they come home, who are the vulnerable elderly at home. And third concern is whether children can trigger the community outbreaks. So there have been papers, there have been studies, and all three concerns are ill-founded. They have found that children are very mild infections or asymptomatic infections is the rule. Almost zero mortality in children from COVID. And children with comorbidity may be little vulnerable, but healthy children, because physiological also they have got a very healthy thymus gland, which helps in immunity, T cell immunity particularly. Then they do not transmit, because most of them are asymptomatic. They do not transmit to adults. Most of the studies they have done, they have found the children get infections from adult rather than vice versa. And also they have found that opening of schools did not increase the transmission in the neighboring community. Unlike the influenza epidemics can be precipitated from schools. By opening schools can trigger influenza epidemics, but COVID, they found that the schools do not drive the community transmission. So schools can be very safely opened, because then now there is a lot of it has become a political year. Without vaccines you can, in fact, the UK also has given a recent year guideline that they will not be vaccinating children. So children vaccination is not going to come in the near future, because there are a lot of concerns, risk benefit concerns, because as it is, children are not very vulnerable to COVID, but we don't know the harmful effects, or we don't know the full effects. The trials in children has not been completed. So we cannot keep the schools closed indefinitely. So this is something which is the agenda now, how to open schools. And if we take the example of Sweden, we can safely open schools. Then we have to see the COVID-19 in perspective with other public health problems. Public health is not only one disease. Public health, we have to consider other diseases, whether life lost is life lost, whether it is from COVID or non-COVID. In a young country like India, if we take care of the vulnerable, if we take care of the people with diabetes, if we take care of people with comorbidities, we will come to that. That is the basic problem. We do not have a good public health services. We do not have a good, Indians are disadvantaged because they are susceptible to non-communicable diseases like diabetes and heart diseases and hypertension a decade or 2 decades earlier than the Caucasians. So these are some of the So now we take what is the actual burden of COVID-19 in India. The case fatality rate, admitted cases vary depending on demographics of the population. Like in Italy and Europe, the case fatality rate may be average age or median age of people dying is 80 years. So that is something which cannot be extrapolated to the countries like India, which has got a younger population. In India, the case fatality rate is around 1% among admitted cases. It is less in the second wave because perhaps we have got better management. Because in the first wave, the case fatality rate in India was around 3%. And the infection fatality rate in India is, if we include the asymptomatic, the infection fatality rate in India is less than 0.1%. Whereas globally, because it is elder population in the northern hemisphere, globally the infection fatality rate is 0.3%. So first is the risk of getting infection. Secondly is the dying form. So the risk of getting an infection in the general population and dying form, it is 0.3%. So if average citizen in India, even if he or she catches the virus, has a 99.99 chance of surviving if he or she does not have any other illness, any comorbidity. So this is the actual threat of COVID. Then case definition of COVID also, because every day there are the number of deaths of COVID and COVID cases. So unlike other diseases, anyone with a positive RT-PCR, that is even one fragment of the virus, dead virus is in the throat or nose, that is picked up as a case. No other disease we are so particular in labeling a case. Usually person has symptom, then we do the lab test, then that person is labeled a case. But in COVID, all contacts, asymptomatic also. So even if a person is not infectious, even a person is asymptomatic, even a recovered, that is carried up as a case of COVID. Death certificate also, if a person dies of heart attack or diabetes or any other, even terminal cancer, all hospitals, they are doing the RT-PCR, and incidentally, if that person is found to be RT-PCR, it is labeled as a COVID death. So this is likely to inflate the death statistics from COVID, because these people are not dying because of COVID, but they are dying with COVID. They are just harboring the organism. Whether that caused it or not requires data cleaning. So in India, daily 25,000 people die in India from various causes. Every day in India, about 25,000 people die. So if you see, if you say zero prevalence, now they have done zero prevalence study, 70 to 80% people are infected or recovered or whatever. And most of them, about 50 or 40%, those who have recovered may be harboring some particle. And if you do a RT-PCR and that person gets another disease, so if, from the 25,000, if you do RT-PCR, you may find 10,000 people may come out to be RT-PCR. So this is, so even dead particles. So a lot of data cleaning required to solve these dilemmas. So there is a lot of debate on that. And so just the figures may not give the true picture. Sometimes it may underestimate, sometimes it may overestimate also. Then known COVID diseases of concern. Then, as I said, this too much of attention to just one disease, it has caused the other public health problems. Child mortality and morbidity. I don't know how many are aware. I have been even talking to some of my medical colleagues, so they are very surprised when I say every day we lose 2,000 children in India from preventable causes. 2,000 children every day die in India. And now there are estimates, because of poverty and malnutrition, this may go up to 3,000 to 4,000 children. That is the estimate by UNICEF. So you can imagine that. And now we are worried about vaccination of COVID for children, but the other, without non-COVID cases, 2,000 to 3,000 children are dying daily, just because of malnutrition, just because of, say, other vaccine preventable diseases which have suffered due to COVID, like measles, diphtheria, whooping cough. Daily deaths due to tuberculosis in India is about 1,500. Over 400 young people die from road traffic accidents and 10 times disabled for life. You see, traffic accidents is a major killer of young people, and many people get invalidated, disabled for life. And now we are worried of 0.5% or 0.1% go for long COVID. There's a big fear and panic of long COVID. But traffic accident is staring us in the face. Infant mortality, a child born today in India has a 3% chance of dying before the child reaches the first birthday. We have got out of 100 children born, 3 child dies because preventable disease. And COVID mortality in children is less than 0.001. Malaria, dengue, typhoid, hepatitis, many other communicable diseases. If we start counting, we may find it there may be much more than in COVID in India. You see what happens, this Western countries, COVID is the only communicable disease of concern. So for them, panic, and we are just blindly, we should control, but we should not lose the perspective. We should, the life saved is a life saved, whether it is saved from typhoid, hepatitis, measles, tuberculosis, road traffic accidents, or COVID. We have got a younger population, or chances of dying from COVID is very, death is a tragedy in any case, but all chances can of dying from COVID can be still reduced if we take care of the risk factors, which we come to it. This is something on health literacy. I hope this COVID has brought to attention, and it has increased the health literacy of all citizens, because with the economic development, with IT sector, lot of sedentary job, India is the diabetic capital of the world, and diabetic is a major risk factor for morbidity and mortality from COVID, and including the mucormycosis. This was the major black fungus. So 99% of cases of mucormycosis were in diabetics. And we have done studies, and in our field practice area, there is almost equal diabetes nowadays in rural areas also. In our rural area, we found 10%, and even urban area, we found 10%. And the most concern was that many of the young diabetics, like 35, 40, they were not aware of the diabetic status, because diabetes in the initial stages do not give any symptoms. The blood sugar is, and if these people, they get COVID, they are more likely to, they are high risk people for mortality or morbidity or black fungus. And if their diabetic status is not known, it may raise the alarm that young people are dying, those who have got no comorbidity. So there is no proper services for detection of diabetes in young people we require. Then genetic factors predispose. As I said, Indians are couple of decades earlier, we get the diabetes, and due to central obesity and fat distribution, compared to Caucasians. They get this non-communicable diseases in the 60s, 70s, and 80s. Indians get it from 30s, 40s, and 50s. So this is a vulnerability. So the COVID, care of COVID, and to bring down the mortality, we have to have the overall health services of this, particularly care of the non-communicable diseases. And the lifestyle is changing in the young generation. Sedentary habits are increasing, and obesity is increasing, rural and urban area. These studies also we have done and published. We find the risk factors like central obesity, waist-hip ratio, gradually they are increasing our young people. And this obesity per se, if we have see the mortality, the overweight percentage is almost 60% in the northern hemisphere, the Western countries. And in our country, it is around 20%. So the Westerners are 3 times more obese than us. And there the mortality is also higher from COVID. But in India, the middle class is already going into the pattern of the Western country. The middle class is obese. The middle class is having hypertension, higher prevalence. Middle class is having diabetes. This lifestyle changes, and the middle class requires the literacy from schools and colleges. Similarly, we found the vitamin D deficiency in our studies we have published. We found the younger generation were 4 times more likely to have vitamin D deficiency compared to the older generation. And this vitamin D is related to immunity and other things. Because the younger generation is spending more times indoor, they are not going outdoors, they are not, and particularly with this lockdown, vitamin D deficiency must have increased, obesity may have increased in this 1 year. Then dietary changes, high sugar consumption, and this is also a major concern. It becomes a habit from school, college onwards. These are the points which I would like to stress on the health literacy, that overall healthcare will not earlier we used to teach that this lifestyle, physical exercise, diet, and all these things are important to prevent the non-communicable disease. But now the COVID has taught us that it is also important to prevent the adverse outcomes from communicable disease like respiratory diseases like COVID and maybe other respiratory disease also. Now, how we go forward, the way forward, how to come out of this COVID-19 Zugzwang. Zugzwang is a chess term that whatever move you make, you are going to lose. So we have now with this too much of restrictions, too much of lockdown. We don't know. We have closed the schools. We don't know whether we open the school or keep it closed. If you open the schools, if you open the business, some cases rise. The issue becomes political. Again, they close it. If you don't open the schools, don't open the business, again there is economic loss, and again you are criticized. So this is a situation in chess. Whatever you do, you will be criticized or you will lose the game. So how do you come out as a short-term measures? Now there is a question of vaccines. Now the vaccines have come, which is a important tool for us. So now, as a theoretically, it is very easy to say the vaccinate the whole country, but logistic problems are there. So if we want to use the vaccine in a cost-effective manner, the priorities are there, which is already there, that people, elderly people and people above 45 years and 18 to 45 years with comorbidities. Now, of course, they have opened up for the whole year, but if you go scientifically, better would be if you want to preserve the vaccine and get the maximum benefit out of the vaccine, you identify the vulnerables and focus protection to elderly and people, young people with comorbidity. If vaccines are available, then give it to others. Then that would be the smart vaccination strategy. And then there is other debate that shall we exclude people recovered from natural infection. Of course, they say that natural infection may give, long term may not give, but there are recent studies now. We have also done a study. We found that even after 8 months, 9 months, the people did not. We followed more than 1,000, about 1,080 people in the first wave we identified who had the infection. We followed them up for 8 9 months. Out of this 1,080, only 13 people got a reinfection, which was very mild, and they recovered. And you must have read about the news in the first case also. She also got her infection, which was very mild, asymptomatic. So for all practical purposes, and there are studies from other countries also, where found that the natural infection gives very robust immunity. So scientifically, if we go scientifically, if we do a survey, we will find 70-80% of people have already have encountered the natural infection. So we may save 80% of a vaccine, because if there is a vaccine shortage. So, and again, vaccine is not a panacea. Like UK, if you see the UK cases, again, daily they are having 40-50,000 cases, same as we are having. We are a population of say 130 crores, and UK is a population of just 6.5 crores. So UK, they are such developed countries. UK is not able to cope up with vaccine of 6 crores. So it would be unrealistic for us to expect that we will be vaccinating 100 crore people or 50-60 crore people, and then we will control it. So the UK, small country, is not able to do it, which have got more resources. So vaccine should not give us false hope. Vaccine is a tool which can help us fight, but it will not the only tool. So long-term measures are improvement of overall health services, improvement of care of diabetes, care of hypertension, good child nutrition. And I am concerned now that because of the poverty, because of loss of employment, economic setbacks, many children will be malnourished, and malnourishment will decrease the immunity, and they may fall victim to COVID. And COVID may be severe in children. Pediatric COVID may be not directly due to coronavirus, but under a background of malnutrition. So if your child is healthy, child is well nourished, COVID will just not touch the child. Then children, good nutrition; adults, care of non-communicable disease, care of lifestyle, dietary factors in the young and old, and care of comorbidities. If we take care of that, COVID will be a very of public health impact of COVID will be very, very low in India if we take care of the comorbidities, if we take care of nutrition, if we take care of lifestyle, and if we use the vaccines judiciously. So this is all I have. Yeah.
Thank you, Dr. Amitav. I think we really needed to talk about these post-COVID issues now when the situation is stabilizing and people are getting back to normal. So, if you're okay, then there are some questions we would like
Yeah,
to
yeah,
ask.
I am ready. I just stop sharing the screen. How do
Sure,
I stop sharing the screen? Just give me a minute.
awesome.
Yeah, screen share करना stop करना है. Screen share stop.
But your screen sharing is already stopped. We can only see you on.
Just stop.
Yeah,
Screen
it is
sharing.
stopped. Yeah, it is
Yeah,
stopped.
yeah, I'm comfortable now. Okay.
So, doctor, you know that most of the people who are watching this lecture, they are family physicians, general physicians, consultant physicians, a lot of people who are practicing dentistry. So, that we understand that they are going to be the touch points for the patients, okay? And now, when people are coming back for the elective procedures for all other diseases that they were suffering from. So, what role or what understanding these physicians should have, or what kind of counseling or what kind of way forward they have for with the patients.
The patient, firstly, they can assess the risk of the patient. I mean, overall health, like if they have got any diabetes, the blood sugar should be, diabetes should be controlled well. If you have got hypertension, it should be controlled well. The care of the primary disease. And of course, if whether they can have taken the vaccine or not, or they can do an antibody test also if they have suffered the natural infection. If they have suffered the natural infection, then one can safely say that yes, the person is protected, and the vaccine may be an additional even if the vaccine is protected. So because vaccine is available now, when vaccine was not available, it was only and even after the vaccine, it is not a foolproof. I mean, there is some risk of transmission, but still that person is protected from severe disease.
Correct, correct. Correct. Okay, that was a very nice answer. So, taking ahead the same question, now when people will start coming back for elective surgeries to the hospitals, okay, and to the clinics, nursing homes for small procedures. So, how to go about that? What are your views on the same in the coming time, with the third wave anticipated and with the vaccine status to still only to 40% that you have already told. So, how should a physician go or counsel the patient about elective surgery?
Healthcare workers are protected because vaccine is for those who are particularly working in dentistry. They are in close contact with the people, so they are
Correct,
frontline
correct,
workers. So they are protected. They get the vaccine on priority. So once they are protected, at least they don't suffer from severe disease. And the patient can be also, if the patient is young, even if the patient is health is good and a young patient, COVID is very mild. So there is no fear of COVID. If the patient is having, even a young patient is having some comorbidity, better that person is vaccinated and protected. And of course, the sanitation and ventilation, good ventilation, and
correct.
personal protective measures, those were the conventional. Yeah.
Correct. So, what are your views about commencement of physical classes for the MBBS students?
It shouldn't have MBBS students. Classes should have not been stopped because young people are quite. They do not suffer. At the most, students may have some comorbidity. They are people with some obesity or endocrine disorders or diabetes, young diabetes. They have to be careful. A healthy young person, as it is, 80% Indians are already had the infection in spite of the measures. So we might as well could have carried out with the young people of schools, colleges. Yeah, we have done survey in Pimpri Chinchwad. 70% of the young people are also infected. 6 years
Also,
to 20 years. So I mean, by closing the schools and colleges, we have not protected them from infection. So we might as well have continued. In fact, I keep suggesting also that schools, colleges could have more outdoor activity. They could have classes in the verandas. They could have say classes, play sessions. They could have playgrounds are closed. If they will have better immunity, they will get vitamin D, and the transmission outdoor is zero for all practical purposes. So this we gave the wrong signals from the beginning. Ki don't step outdoors. In our India, indoors is very congested. Outdoor is safe. So schools are the play. They could have had some play classes, I think.
Right, right. Makes sense. So now coming forward when the after the lockdown, when we are entering that post-COVID era again, so what are the new health policies we are looking at?
I think we should take a life normally now because I can understand the apprehension, great apprehension rather, because after the first wave people stepped out. But if you see the data, after the first wave, the seroprevalence was 21%. That means 80% of our people were still vulnerable, 70 to 80%. And what happened? Why? And then the people question ki that time also curve came down. That type curve came down in a different manner because this time also when we did the last time we did a survey, Pimpri Chinchwad, again after the second wave, the survey was repeated. Different team did it, but the findings are very interesting. In the first survey, 35% we found had encountered the virus in Pimpri Chinchwad. But this was not homogeneous. We found the 70-80% of tenements and slums. They were having the antibodies, whereas the 5-10% in the housing societies were having. This time, what happened? That means the people who had to work with the hands, they had to go out for a living, they got infected and they developed herd immunity. And the 70-80% of the middle class and upper middle class, they worked from home. They could do the COVID appropriate behavior, and that stabilized. The incidence came down. But it gives a false sense of complacency when this 70% came out, stepped out after the first wave. They all got infected. So the second wave was very sudden and unexpected because the high 70-80% people were left vulnerable. And this time when we did the survey, we found that 80-90% of the middle class also got infected. In fact, I also had a very high antibody level. I mean, I had no symptoms. I have got 10 times higher antibodies and I did not take vaccine yet also. So I didn't know when I got infected. I am elderly also. And in fact, I was for a surgery, I was on steroids. So I deferred the vaccine thinking the vaccine will not work when I'm on steroids. But still I have got antibodies. So I am that in the 80%. So now most of the Indians, I presume, may be stable now, and I think we can open up, and of course we can keep an eye on it how the things are here, and the rest 20% can be vaccinated, those who have not faced the natural infection. I think now we should go for rapid antibody surveys. People should be encouraged to do the antibody testing, and if you don't have antibody, go for the vaccine. If you have antibody, you can wait back in the queue. You can save the vaccine for people who have not been exposed. So if we follow the policy, we can just with 1/10 of the resources, we could vaccinate, we could get herd immunity for the whole population.
Correct, correct. That totally makes sense. So you are in public health. We all know that you have been working in public health and policies since the start of your time, and you have various experience in varied experience in various fields. So from the entire medical fraternity, what are the health policies you would want to suggest to the government to start implementing post-COVID?
Health policies may most important are particularly the public health infrastructure, particularly in the remote areas, rural areas, district hospitals, because this will prevent most of the deaths have done to the overwhelming of the health services. In fact, we would have a much less mortality if the health services have been equally distributed. And this is the most important. And the health literacy, as this is one of the topic today, health literacy, the middle class is becoming vulnerable to this type of fear, and it is going the western. I mean, the young people, particularly the lower socioeconomic people, were not much affected by COVID. The affluent were most affected, particularly mortality. In fact, India is such a large country that we have got one Africa inside India, one India, one America inside India, one Europe inside. I mean, our culture is so varied now, and we are blindly going for this fast food and other thing. So government policies on this awareness, and of course the care of all health conditions like this soil is very important for COVID, particularly diabetes and non-communicable disease and obesity. These three, and the western mortality is also high because of that. And of course focused protection of the elderly, those who are elderly.
That was a very precise answer, doctor. So that brings us to the last question. That are we prepared for the third wave? If at all we hit a third wave, is the country prepared for a third wave?
Yeah, definitely. I mean, firstly, because of the prevailing seropositivity level, I don't think the third wave is going to be very severe. The second wave was severe. There is a reason for it. 80% of the people were vulnerable. And
Correct.
the third wave, we hardly have 10, 20, at the most 20% people might be vulnerable. They could be covered by vaccine, firstly. We have got a tool. Secondly, I don't believe the new variants will make a dent given the natural infection. Because there is a lot of fear that you get Delta variant and Lambda variant and so many other variants. But you see, a person who gets a natural infection, the virus is in the body for 15 days, the immune system becomes very familiar with the virus. So if there are minor changes due to mutations, the whole virus is recognized by the T cells of the bodies, by the immune cells, by the memory cells. So even if the various variants are there, natural infection will protect our population, which are already reached some level of population immunity. And as I said, if you can identify people who are vulnerable and who have not been having the antibodies, they can be covered on priority with vaccine rather than rolling it out to everyone who have also suffered the infection. I mean, that would be not very economical given the resources, vaccine resources.
Correct. 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 Thank you, Dr. Amitabh. That was a truly insightful session. I think we need to talk more and more about such issues because now, people have a lot of questions how to go about COVID, the counseling, even the healthcare workers have a lot of questions. So I think you covered it in a very precise way. We look forward to hearing from you again. Thank you for taking out time from your busy schedule and coming and talking on this important thing. And to all our viewers out there, we appreciate your enthusiasm. We appreciate you taking your time on a Sunday evening, coming and listening to all these things because, of course, knowledge is something that is going to help us fight the disease, fight the pandemic better. Thank you, all of you, for attending the session. Please stay safe, stay connected. Happy Talk Flexing. Thank you, Dr. Amitabh. We'll see you
Thank
soon.
you. Thank you. Thank you.
Bye, sir.